without forgetting, the co-host is Sheila Ogoma. Thank you very much for doing this. Sheila and Fredros, these are all IHI people, although behind I can see Clinton Foundation, but she's IHI. So Fredros, basically, I just wanted to thank you really for taking the time to share what you know around malaria control. There are various topics that Fredros will be covering. I'm sure you've had a prior engagement, but I think it also provides an opportunity for people like you have the at different levels have been able to finance or support malaria control programs across the globe, and therefore you have definitely a broad knowledge of what are the challenges, what are the issues, and solutions that have come up from implementing malaria control strategies across the different countries with different epidemiological intensities. So I hope people will enjoy to have that opportunity. Thanks to technology, we can all sit in the same meeting from different time zones. Some it's in the morning, some it's in the evening, even some it's at night. But that's the beauty of technology these days, that you can be in one room or one place and get the knowledge and share and connect and everything. So thank you so much for taking the time to do this. Fredros, back to you, and Sheila.
Thank you, and thanks everybody. Thanks to Sheila as well. You probably noticed already that the meeting is being streamed live on our YouTube channel already. Meera, it's nice to meet you for the first time. Welcome to Fakara Health Institute. My co-host is Sheila Ogoma, who used to be with us as well, but now works for the Clinton Health Access Initiative. This meeting has attracted a lot of participants, a lot of attendees. We have on the line at the moment 150 people waiting, and I think the number is going to continue increasing. We have just over 370 people registered for the class. Typically about 3/4 or half of them attend live and the rest watch on our YouTube channel. So we expect there'll be a lot of questions, a lot of chat and all that. So I'm just going to invite everybody right now. Everybody will stay mute, and then we will continue with the conversation, except we will request the speakers to all stay with their videos on and the audios on as well. Before I do that, I'm wondering whether either Phillip, Helen, or Meera, you have any questions for Sheila and myself.
No, looking forward to a really good discussion.
Thank you.
All right, thank you so much.
Thank you so much. Before you go,
yes, please. Yeah.
Sheila is still IHI alumni, so.
Correct.
I'll make sure I change this.
Okay, you can proceed.
Yes. I believe you can see my screen.
Yes.
And we are just now inviting everyone else into the room as well. So this is going to take maybe 1 or 2 minutes to let everybody in, and then we will begin the conversation.
Hi, how are you?
Very good. How are you?
Very well. Thank you very much.
Helen, what time is it where you are? You in Seattle?
Yes. Yeah, it's
so
5.
It's like 5 in the morning.
Yeah. Early
Guys.
start. Yeah.
Sorry to you guys.
We always have that problem in Seattle.
Yeah. When we have a class with the people from the Pacific, we try to start a little later, but a little early, so it's not too late for them. And if you have a class with people from the Atlantic, then you have to start late, trying to get a balance. 2 o'clock East Africa time seems to be the best for us.
Yeah.
But hey, you may have to get up early, but you get the rain, so I mean, you got best of both worlds.
Yeah, and actually we have a beautifully sunny week this week, so
Yes.
I have to say it's absolutely wonderful to be able to have these kinds of meetings and not have to jump on a plane every 5 minutes.
Yeah, that's right. And for our colleagues who join, especially the postgraduate students from across Africa, it's really been helpful that we can talk directly to the experts without them having to travel to conferences and to arrange meetings with the experts. Yeah.
I'm just saying hello. I'll disappear.
Hey, Fred.
Hey.
Nice to see you.
Hi, Helen.
Hi, how are you?
Hi, Phillip. Good luck.
To see you. Just a quick note to our experts today. We will have, for a brief moment, a guest co-host with us, Dr. Samson Kiware, who has a few questions to handle on mathematical modeling. And so he will mediate some of the conversation with Phillip. So, Sheila, as people are still joining, we already have 175 people on the line. So perhaps we can just start. Is that right, Sheila?
Yeah, we can start.
Would that be okay?
Yes.
Okay, let me just set this up. Dear colleagues on the line, welcome to the 23rd edition of the Efficacy Health Efficacy Masterclasses. We are delighted today to host the three of our friends and experts. We have Dr. Phillip Welkhoff from the Gates Foundation. We have Helen Jamet, also from the Gates Foundation. And then we have Dr. Meera. I have to learn to pronounce the second name, but let me say for now, Venkatesan from the President's Malaria Initiative. Meera, is that the correct pronunciation for your second name?
It was perfect. Thank you, Fredros.
Perfect. Thank you. We apologize for asking you guys to join so early from your time zone. But good morning to our colleagues joining from the Atlantic, and good afternoon to our colleagues joining from the Pacific and from East Africa and Europe. Thank you all very much for participating. As always, this masterclass is being streamed live on our YouTube channel. And we are also going to be having an active chat box. So if you have any questions, please throw in your questions in the chat box, and you are also welcome to participate in the Q&A, so you can answer as much as you like. You can try, the Sheila, myself, and Dr. Kiware will be joining us at some point. Please, if you really have to say something, we ask you to send us a private chat message. Otherwise, we will ask all our participants to stay muted. Keep your video and your audio mute, except for our experts and the co-hosts. Good. So once again, good morning. I wanted to begin by making a correction. A number of people sent us an email and requested a change in the spelling. Apparently, we sent out a note with Malaria Dalenda est. The correct spelling, the Italian version, is Dalenda est. So we just want to make that clarification before we proceed. And actually, on that note, I would like to begin by asking Phillip. Thank you for making time to join with us here. A few years ago, I remember being at an IVCC meeting, which was either in Liverpool or somewhere else in the UK. And there was Dr. Alan McGill and Admiral Tim Zimmer. I don't know if this is the correct pronunciation of the name. This is a long time ago. And I remember them talking about what their job descriptions were at that time. And Alan was saying that his job description was apparently the shortest because it simply said eliminate malaria or something like eradicate malaria. A question to you, Phillip, is whether your job description is the same.
Yes. So I think when we look at what is the vision, what is the goal for malaria, at the Gates Foundation. I think we've had that as a clear North Star since October of 2007. This is a big and ambitious challenge, and is from there is a multi-decade effort to get to the goal. But I think when our leadership, Bill and Melinda, we're looking at the problem, and we're looking at what do we do in the face of malaria. There were a couple challenges that really drove them to say, the solution and what the goal of this effort can and should be is malaria eradication. And when we look at how fast malaria can snap back if you push it down and then relax, we saw this when both for when programmatic relaxation happens, but also in times of disaster, in times of outbreak, in times of unrest. We see what happened with Sierra Leone during the Ebola outbreak about a half decade ago, when distribution of nets, other means of public health control break down, access to care breaks down. Malaria is very unforgiving and rises very rapidly, and untreated malaria is devastating. We also see that, as we make progress, one of the key drivers of reduced malaria is economic growth and development. And a lot of our gains over the past decades have been due to economic growth and development in malaria-affected regions, which means that as we continue on and on, the remaining malaria burden becomes more and more concentrated in poorest populations. And so if we have any goal that does not say, oh, we need to get all the way to zero, we're basically saying we're okay leaving malaria in some of these areas. And when Bill and Melinda were talking about this, they said, you know what, there is no acceptable level where we say, okay, we can clear it out of these areas, but leave it in these areas. And so the only goal that made sense, the goal that they were talking about in 2007 that really drove the most equitable approach, was fully getting to zero. Now, they realized then, and I think we've learned even more since, about what a tremendous challenge that is. We don't have the tool set in hand that's required to eradicate malaria. But you can actually either look at this and say, oh, this is just a long-term aspirational goal, or you can say, no, this is the goal that we need to have. What does it take to make this concrete? And so when Alan McGill came into this job, his job was to take this and find a concrete way to actually get there. And I remember I had been partnering with the Gates Foundation externally before I went there, but I remember when there was a possibility of him coming to take the malaria director job. And basically his message was, I'm coming here to eradicate malaria if that's, and if you let me eradicate malaria. He wanted, the ability to go out and push forward on this. And everyone was really enthusiastic for that. And then there was his tragic death. The mission remains the same. And the reasons for the mission not only remain the same. I think what we've learned in the past decade, even more so, is that there is no long-term making peace with malaria. There is no level at which we say, okay, we can reduce it to here and then we're okay. Malaria snaps back. We look at what happened in time of COVID with how much heroic work programs, communities, national malaria programs are doing, global partners are doing across the world to prevent what could be a catastrophic snapback and losing, 2 decades of progress. And we don't want the world to be in a situation where anytime something goes wrong, a pandemic, an outbreak, a financial crisis, unrest, that hundreds of thousands of people could die. And so, yes, that was too long of an answer, but a long answer for a short job description. My job description is still yes, to eradicate malaria. Over.
And on that basis, we we can say, therefore, malaria must be defeated.
Indeed.
Is this the correct translation of malaria Dalenda, right?
Malaria must be destroyed, indeed.
Malaria must be destroyed. I believe that both Helen and Meera agree with us. And by the way, Samson Kiwara, if you're online, we'll ask you to turn on your video as well, so you can join with us. Anyway, let's move forward, and I'm going to invite my colleague Sheila Ogoma to pick it up from here. Sheila, please.
Thank you very much, Fredros. To follow up on destroying malaria, we've seen that it hasn't been really easy in terms of eliminating malaria in African countries. It has been eliminated in Algeria, but why is this so? Why haven't we been able to eliminate malaria in most African countries? Helen, would you like to take us through this?
I'll make a start, certainly, and maybe hand over to Meera and Phillip to add on. I think it connects very well with the previous question. Malaria is completely preventable, so it is absolutely the right thing for us to be doing in terms of our goal to eradicate. But we have the ability to learn as we go along, which is something that I think the global community is doing very well, and pivoting when we have big challenges like COVID-19 upon us. But it's also a hugely complex disease and requires multi-disciplines, multiple partners, all collaborating and coordinating together. In Africa, we have some very challenging mosquito vectors that love to bite humans, that live for a fairly long time compared to other mosquito vectors, and are very good transmitters of malaria. We have had massive inroads with the scale up of bed nets over the last 15 years, which have really, really helped to bring down transmission and case rates and mortality rates, but some stagnation happening, which could be due to multiple things. Some of the important areas that really need to be addressed, that I think are big challenges, are related to the buildup of insecticide resistance. We also have drug resistance starting to appear in Africa now, which is highly concerning. And also the quality of bed nets. Bed nets need to be have insecticide and be intact to prevent mosquitoes from attacking people inside. And if they start to fall apart and people aren't using them, then we're not getting the coverage rates that we require to have the impact that we need. On top of that, we have other factors that are related to changes in transmission patterns. So there are increasing areas reporting mosquitoes biting at different times of the day. So very early in the morning, late in the morning, or earlier in the evening outdoors. And it's clear that whilst we need our current tools to work, to continue to work, we also need some additional tools that can really help us to get to eradication in some of the hardest places. There are areas where you have complex emergencies, very difficult to get to, conflict regions where it's just impossible to set up good malaria control or consistent, sustainable malaria control campaigns, and that linked with the need to build good health systems across endemic countries. A whole variety of other factors, I think, are really highlight the fact that it is highly complex disease that is related to many different factors. Poverty, housing, the environment. So I think that's part of the reason. If we look at Europe, a lot of the Europe and the US, when malaria transmission was happening, it largely was controlled because of the way that the built environment changed, that basically led to reduction of or no breeding sites, and that combined with some of the earlier insecticidal tools largely led to the elimination of malaria from those regions. And I think in Africa it's more complex, but we are moving towards moving in a direction where we should have a multiplicity of tools available, and partnerships and various other interventions in the health system to help address some of these issues. Let me hand over to Meera and she can just add on.
Helen,
yeah,
just very, very quickly on that specific point, Sheila, if you don't mind, I just want to follow that up. So Helen, would it be right to, I mean, typically when people discuss this topic, an impression is created that the African countries are not doing something right, that the countries that already eliminated malaria knew what was supposed to be done and they did it. But what you were saying earlier is also that the epidemiology of malaria in Africa is very different, and that it is much harder to eliminate malaria in Africa because of that epidemiology, and that we shouldn't assume necessarily that we could just pick up whatever it is that the US did and have that work in Africa. Is that what you're saying, Helen?
Absolutely. I think you have, unfortunately, really good transmission in Africa, and it was never quite as good in certain other parts of the world, particularly if we look at Europe and North America. For example, the vectors there don't have quite the human biting propensity that they do in Africa, meaning that they pick up less, on average, less parasites over their lifetime, or that they did when they were vectors. And so I think it's core to the challenge of eradicating malaria in Africa.
Thank you. A lot of the people joining these calls are postgraduate students. Many of them are researchers who have either just joined or practiced for a long time. And so if you find any specific, technical detail that you would like to emphasize, please feel free to do this. Also for the benefit of the early career researchers who constitute almost 50% of our participants. So, thank you so much for that clarification. And I'm sorry I interrupted. So if someone else wanted to do that, Sheila, back to you.
Thank you, Fred. I think we've covered that. We can move on to the next one.
All right, okay. So actually, our next question is related to the World Malaria Report, the last one we have from 2020. And this is an interesting point, actually, because we've had a masterclass with Abdisalan Noor, who is in charge of this production, but also with Professor Pedro Alonso recently. And one thing they are both emphasized is that this was a special report in the sense that they also did an overview of the different milestones that have happened. The question we have here, and maybe we should send this to Meera to begin with, is if you look at this report compared to the rest of the reports, what are the unique features of it that constitute the greatest lessons for us aiming to eliminate malaria in the years ahead?
Sure, thanks, Fredros. Maybe I can kick us off, and then definitely curious to hear from Phillip and Helen what their major takeaways were. I think just to start off by saying it's an extremely comprehensive, almost a compendium. The report is really kind of a standalone, in-depth look at progress against malaria over the past 20 years, as you've noted, really kind of taking a deep look back. And then I think it has a lot of lessons for what we need to be doing moving forward. One of the pieces that struck me was some of the equity analyses that are included, looking at the coverage and access of some of the different interventions. And notably, I think, Helen did a great job, especially highlighting from the vector control side, some of the challenges that we see in Africa. Well, that the other side of that, of course, is the parasite and the treatment side. And I think one of the pieces that really struck me was looking at both the reporting of the frequency of fever in the past 2 weeks, as well as the likelihood of care seeking in children under 5. And I thought that the maps showing that really children from poor households both have higher likelihood of having had fever and are the least likely to have sought care is a really important lesson moving forward. And Philip's point that we can't not eradicate malaria, because in doing so, really then accepting that the poorest and those with least access to care don't need to be served, I think is a very important point. And moving forward, we're almost, in one way, we're fortunate to be in this position where so much progress has been made, and we have really increased the coverage of many of our interventions in the past 20 years. And yet now we have to look ahead to see who are we missing and what do they need and how can we reach them. And so to me, that message of equity, but also how in reaching those who aren't being served is actually going to get us to the next stage, was a really important message in the report.
And when you say, when you talk about the concept of equity here with the malaria control, can you elaborate just a little bit how PMI, the President's Malaria Initiative, views this concept of equity in the fight against malaria as we move forward?
Sure. Well, with the coming on of our new U.S. Global Malaria Coordinator, Dr. Raj Punjabi, this is an area that is very near and dear to his heart, and something that he's thought about quite a bit in his previous work in really trying to extend access to care to communities that don't have it. And so I think we're very fortunate at this time that the rest of the world is really starting to focus on this issue more, that we also have leadership with expertise and real interest in pushing us forward in this area. So for PMI, in our strategy that's under development, we will be strongly highlighting the importance of reaching those that are facing the high burden of malaria and also not receiving services and interventions. So who are these communities? How can we identify them? And then how can we figure out how to serve them? It's definitely a complicated problem. I think for one thing, I don't know that anyone has an answer to how to easily even identify these communities to be able to access them. So I think there's a lot of work collectively that we all have to do. But from the PMI perspective, we're definitely committing to working on this problem and figuring out how we can first find and then serve these communities.
Thank you. Earlier on, Helen and Philip were talking about the new opportunities that we have. And I would like to start with Helen here, but then also hear from Philip. If you think about what has happened in the past 20 years, in terms of diagnostics, drugs, vaccines, and vector control, and depending on your interest area, you can focus on either of those. Which tools would you consider the most significant in this period that has come through? We can start with Helen and go to Philip.
Well, of course, I would say bed nets.
Okay.
I think if I had to choose, I would probably say certainly bed nets and diagnostics. I mean, I think that some of the advances in our treatments have clearly been absolutely dramatic and needed as well. But if you think about where we were at the early part of this millennium, so early 2000s, we had we were kind of coming out of that big discussion around how do you put insecticides on nets? How do you make sure that people, when they wash their net, can dip it again to make sure that the insecticide always stays on? Obviously, because it washes out every time you wash your net. And there were all of these discussions around whether you should have community dipping or sachets of insecticide and instructions for people to dip their own, and then relying on people to make sure that they dip their own. And the invention of the long-lasting insecticidal net that enabled the net to be washed and the insecticide to go back to the surface afterward. And the demonstration of the impact when you get to coverage, the cost of distributing those nets through campaigns to get to coverage quickly, essentially enabled us to scale up net use to unprecedented levels, where we were able to quickly get to high coverage levels to get really good impact. And I don't believe that would have happened if we hadn't have had a technology that was as elegant as the long-lasting net. So I'll stop there and hand over to Philip to add on.
Yeah, just before that, several times I've had Pedro mention that, you know, when they were working with Steve Lindsay in the Gambia, they went to WHO so many times to try and convince WHO to, you know, to adopt the bednet policy. It never happened. In the 2020 report, it's also documented now that the first LLIN was approved in the year 2000.
Yeah,
which is a fantastic coincidence there. Are you saying that if we had not moved from the technology of hand washing to hand treat, if the technology to permanently treat the bed nets had not been developed, it would not have been possible to scale the same way the RBM partnership has done today?
I believe so. And the reason why I believe so is because every time you need to have, you're relying on somebody to have behavior change. So you're relying on somebody is actually going to take their bed net to the central place for it to be dipped, or they're actually going to be reapplying the insecticide. It's hit and miss. Sometimes it works, and sometimes you'll have everybody that absolutely understands that's what they have to do and they'll do it, and other times it won't. And the ability to have a tool that has a certain level of efficacy over the lifetime of the product, and we can argue about how long they actually last and the differences between the different brands and all the rest of it, but the ability to have a tool that is truly long lasting. I mean, let's face it, it's pretty incredible that we have something that you can wash and then it kind of reactivates itself and it continues to kill mosquitoes is pretty amazing. And I you know, it goes back to all of those discussions around whether or not, which were happening almost around the same time that these discussions around how you put the insecticide on the net. Should bed nets be given out for free, or should people pay for them? There was that discussion going on as well, and the bed net was viewed by some in that debate as a kind of similar to a vaccine, because of its preventative, because of the nature of it as a preventative tool, and so the leveraging funding that essentially enabled the mass procurement of all of these tools was another piece of that larger puzzle. But I don't think you would have had that happening if you didn't have a tool that enabled that. So and today we have a multi-million-dollar industry for a tool that didn't exist in the late 1990s. Okay, it existed in one company, but there was no market for it. So,
yeah, no, thank you, Philip. Please, what excites you most?
So I think one of the most important advances of the past 20 years was the new drugs for case management. So I think, you know, so I grew up in Haiti in a malaria endemic area, had malaria frequently through childhood, but chloroquine was effective. And you know, every time I got sick was able to take chloroquine, and it worked. When chloroquine failed across so much of Africa, you can look location by location in terms of mortality rates before the resistant mutations spread in, and then from the few years afterwards. And you could see a averaging across areas, mortality rates doubling. And you know, malaria is diagnosable, but when malaria was for a time not treatable in the same way after the loss of chloroquine, that was devastating. And when there's a disease that we know, that we understand, and then it's clear what a child is dying from, but then not having the tools to save that child or anybody, that's devastating. It was a massive setback. So I think the introduction of Artemis and combination therapies, to where now we have a diagnosed malaria, that malaria can now be treated and cured, has been really transformational, and it really changes things. I think if we then expand to the larger context, what do we need to drive forward, drive down burden, eliminate, and continue from there? Any single location needs good enough prevention of transmission, good enough case management, and good surveillance to know where you need more of each. And so I think both of these are those are the multiple pillars that I think come together to have impact. And the more we can prevent transmission, the less demand there will be on case management and so on. So I think as we look forward, there's a real agenda, a real research agenda, and a logistics agenda on each. What are the next set of tools that we need to help prevent transmission? And then how can we continue to expand access to good case management? Because every death that happens is a failure of case management in some way, often access. You know, there is no one who should be dying of malaria. And I think that sets a real agenda, and improved measurements, improved kind of mapping of where are the deaths happening, where is the continued transmission happening, what characterizes the remaining transmission, and because malaria will have different levels of intensity, different mosquitoes in different settings, and the right mix of tools is likely going to vary by settings in terms of on the transmission side. But every place needs good diagnosis, and then good and effective treatment with access to it. And so I think that has defined that combination has defined a lot of the progress over the past 20 years, and it also defines the progress that we need to make going forward. Though, yeah, and I think we'll talk about some of these things a lot more over the next few hours.
Right, exactly, and we can just circle back on many of these, on the diagnostics, the disposable artemisinin for children. I believe some of our colleagues from MMV are joining the masterclass today, as well as diagnostics. For now, I'll hand over to Shayla, and we can continue from there.
Thank you, Fredros. So Dr. Meera, the PMI strategy is to reduce malaria-related mortality by 50% in the high burden African countries. So the main strategies are these four that we see here: ITNs, destroying diagnostics and treatments, as well as IPTP. Has this changed for PMI?
Thanks, Sheila. I think that's a great question and timely as we're looking ahead with our next strategic plan. Overall, I think our sort of way of working, of really focusing on scaling up the evidence-based interventions remains the core principle of how PMI operates. I think in the global malaria community, the different partners have sort of different roles, and together we complement each other to hopefully move all of us forward. And so our approach does continue to be to really, as we have more proven and evidence-based tools, to use the platform that PMI has across 27 countries and the strong in-country relationships and partnerships to really be able to bring those to have impact. So absolutely, I think these 4 interventions remain core to the program. But over the past few years, that's not to say that we're stagnant. PMI has played an important role in scaling up SMC across the Sahel over the past few years, starting with some pilots in Mali and Senegal around implementation, how it works, how to operationalize and make sure we can deliver at scale. And then over the past few years, really scale that up over, I think, support in 9 countries now. And so looking ahead, I think we're very excited to partner with our R&D colleagues, with our research colleagues, to look at, what's next? What are the next interventions that have the evidence base that now we can help to figure out how to actually introduce and then implement at scale? So, I'm not sure if that answers your question entirely, but we are, building on the interventions that are, still sort of proven and core and working, and then looking at what should be introduced and where. I think on that question, and we may get to this later, there's a lot of work being done on how to optimize different combinations or different packages. With malaria, because we have sort of a toolbox of multiple interventions to hit the disease in different places, and no one intervention is perfect or sufficient. I think, as Phillip mentioned, we need the prevention and the treatment. This question is just going to become more and more important as we introduce more tools to the toolbox, yet we may not have a growing resource envelope. How can we best apply the combinations in different settings to have the most impact? Because we can't do everything everywhere. And so I think we're benefiting now to be able to have more options, but then the complicated question is how do we apply them? And I think that's where some of the important work that's being done with some of the modeling is very helpful. And I know we'll get into that with, Phillip being an expert, and then also some of the sort of pilots and implementation research, as well as having the data from, the location specific data on what your vector is doing, what your epidemiology is like, will hopefully help us to sort of tailor and put together packages. I think as the PMI program, along with the rest of the global malaria community, rightfully so, I think we all started with the goal of sort of universal coverage. Let's try to bring all of these interventions to scale. And now, while many of them need to continue, we don't want to backslide. As we introduce new tools, it may be that some are more applicable in some settings than others. And that's an important sort of question to tackle that will take all of the stakeholders to figure out.
Yeah, thank you, Dr. Meera. Back to you, Fred.
Thank you. Meera, it's nice to hear that. I guess for many of our colleagues, a bigger question here is how adaptable will the PMI strategy be as some of these new tools come into play? Given that, based on your 2005 founding strategy, this core interventions seem to have remained the main focus for this entire period. And so a common question from stakeholders is your next strategy going to be adaptable to, pick up any of the new interventions or newer versions whenever they come in? may
I think
want to
absolutely
respond to that.
yes. And I would argue that we, even in this period, we've not remained static. I think, there have been interventions that we've been able to introduce and scale up. And I think we absolutely are committed to, as the evidence base is formed. Again, it's a question of how to apply a limited resource envelope. But we really, look to work together with all of our partners to really answer those questions. Every time you add, what are you not doing? And is that the right decision? I think those are the tough questions that practically each of our country programs, they each have a budget every year. Those are the questions when you sit down to look at the budget, that's where the science translates into what you can actually accomplish.
Thank you so much. Budget, envelope, these are terms we're going to hear a lot of in this masterclass today. Obviously, because of PMI, many African countries and now also elsewhere have been able to scale up some of these WHO recommended interventions. Actually, if you think about the period before 2005, and even 5 years after that, when PMI was still in just 3 or 4 countries, a small number of countries, there wasn't really much happening, and therefore, on behalf of many of my colleagues, and we have a slide on this towards the end. Sometimes it's nice to just do a little bit of a reflection and say thank you to PMI for the tremendous amount of support that we have received. A quick question here, perhaps to Helen, is when you think about these 2 interventions in particular, for bed nets, we have a much smaller opportunity now in terms of insecticide candidates. For IRS, seems like we still have 3 classes of candidates. And then you see a record such as the figure that the slide that we're showing there is from Julian Tangena, that suggests that yes, indeed, more countries are adopting IRS, but the coverage is staying flat. Then, in addition to this, you have the rise of environmental groups, greater regulation on pesticides. Overall, if you put all these things together with the logistical needs, what are your views on the future of indoor residual spraying, let's say for the next 10 years?
Thanks, Fredros. Great question. I think we are in a place that we have needed to be for a very long time, in that we finally have a selection of different classes of IRS molecule to use, so that programs can do proactive resistance management, which obviously has all of the complexities of needing forecasting and so that companies can excuse me, make sure that they have all of their production and all of the supply demand is properly coordinated. So I think we're in a place now where we don't have the blanket spraying of one class of molecule as we have done in the past. There is and there are a couple of other molecules that are in the pipeline that should be available very soon. Chlorfenapyr is one that's in the WHO evaluation process, and then there's another molecule from Mitsui that should be available hopefully in the coming months. So we're in a place where proactive resistance management of the IRS products is now possible. I think there is room for improvement in terms of how IRS is done. Certainly there's been some efforts in terms of looking at the spray equipment. but PMI also have a big effort to look at whether you can do targeted spraying so that you don't have to spray all of the walls in the house. For example, you can only spray a certain part, which obviously if you're using less spray, then your spray goes further and you can increase your coverage rates. But there's also a need to have accompanying tools to help with the kind of quality control and surveillance part of IRS. So for example, tools that you can easily use in the field to understand what the dose is on the walls and or when you have no IRS left. I think that given some of the given a lot of the complexities around spraying and the fact that there's a restricted budget envelope across the board, it would be over the next 10 years, if there is a possibility to transition some of the IRS to some different markets so that you have more private sector involvement in IRS programs that may be able to increase the budget envelope for this essential tool, that I think would be a really interesting. There's some fascinating groups working with looking at small cooperatives for spraying and how you can do that in so that you're not having large operations across the country, but smaller ones that are then able to run their spray programs on a kind of community basis. So I think there'll continue to be a market for IRS. There are more products available, which is good, and much more coordinated use of those products so that we can hopefully extend the lifetime of them, because obviously resistance is always going to be a problem, and staying ahead of resistance is going to be absolutely crucial.
Thank you. Thank you so much for this clarification. At some time in 5-10 minutes ago, Meera was talking about combinations of interventions and how we use this allow budget envelope that Helen is talking about now. How do we make a decision on what to put in? And we have a question here for Phillip. And Phillip, you and I have discussed many times, how do you make these decisions of what you put in there? There's a school of thought that thinks that, you have your 6 interventions, you throw all of them in and see what happens. There's another group of a school of thought that says, no, we have to select which of those should go first and which of those would be most impactful. And before we ask the question, I just want to show you these 2 examples. This one example, this is work from Mozambique by Beatrice Galatas and colleagues. And they have an incredible demonstration here of how malaria control can be difficult in some settings. You have several rounds of indoor residual spraying, several rounds of MDA in there, you have bed net distribution, and they do this in a controlled setting, so this study is very well monitored. But if you look at the finding, of course there's a lot of reduction in malaria, but going to 0 at some point just becomes impossible. I guess an important question, or 2 questions here. First for you, Phillip, is how do we make that decision in terms of what goes first and what follows, and how many do we have in there? And second, should we just throw in everything that we have in the end, or would we rather do 2 things and do it very well at high coverage? Or if you have 4 tools, should you use all of them, or just use 1 of them but do it very well? Back to you, Phillip.
No, this is such an important set of questions, and I think this is one of those. This is the most important point is, I think there's going to be a need for strategic use of information at a subnational level. We're going to need improved field measurements. We're going to need improved entomological surveillance, and we're going to need good and timely case data from health facilities and community health workers. That as a fundamental level is we're going to need to be guiding the mix of interventions based on improved actual measurements. I think that is a very important point we can't skip over to just say what the tools are. How are we going to guide the use of the tools? I think if we look at the Magude work, there was it was an incredibly well done study. And I think one of the real questions around what does it take to get to zero is that, Magude is not an island. It was surrounded by other areas that also had malaria. And I think if we think about malaria as well, if an untreated malaria case can go on for months or even longer.
Yeah.
And still continue to be transmitted by the local mosquito population. So we talk a lot about the reproductive number of a disease, and one infection, how many other ones can it create? And there's been a lot of discussion around the reproductive number in time of COVID. Starting between 3 and 4. What happens when there's immunity? What happens when you start getting a vaccine out? What happens through measures like masking or social distancing and so on? And the general thing is if you can get it below 1, it starts to go away. But now we think about malaria. And say we were able to get not just to 1, but to 0.5, which means we've done a remarkable job preventing transmission. And then we have 100 imported infections to an area. Well, those 100 are on average going to create 50. And those 50 are going to create 25. Those 25 are going to create, half of that, and so on. And it means that, when you go through all the different generations at a R0 of 0.5, 100 imported infections are responsible for about 100 onward infections through all the different generations. And each of these are months and months of length if they're not treated. And so you can, if you're not also driving down malaria in the connected areas at the same level, and there's that movement of people and continuous source of reimportation, it becomes very difficult to go from low all the way to 0. Yeah. And it also creates a further challenge because there are some areas where within a country that's near elimination, part of the transmission may be driven by importation. But there may be some areas there that have R0 slightly above 1 and where there's kind of stable local endemic transmission. And it becomes at low levels, it becomes difficult with high rates of importation, it becomes difficult to distinguish those two situations because each of them will have a different response that's needed. So I think a key part of this is the better surveillance. I think if you're going from low to 0, making sure that malaria is also suppressed in the neighboring areas is also really important because it's hard to win against the steady tide of importation, given the peculiar timescales of malaria. And then I think the entomological surveillance is going to be an important thing to understand what set of tools is going to be most effective in a given place for driving down transmission. And so, I think the high burden, high impact initiative is actually a really essential one because that's saying, we're not going to just take tools sequentially and just, spread them very thin and then do the next one and then do the next one. It's going to be a very much empowering centered around each country's national program and a strategic plan and saying, how do we improve surveillance, then use this surveillance to guide what mix of intervention should be best in different areas, because the mix of tools that would be used in a urban area is going to be different than in a higher transmission rural area. Right. The last thing that I'll just say is that we talk a lot about innovation for better efficacy, innovation for better duration, and so on, innovation around cost. But innovation to ease logistics is going to be key, because getting to higher coverages is really important. And if we're, say, on a bed net, giving out bed nets repeatedly, but the durability means that there's tears in nets sooner, and nets may get discarded earlier than 3 years. It becomes going on a treadmill. No matter how fast you're doing, you're never quite getting to your goal. And so coming up with tools that make it easier to get the logistics that we get very high coverages with the tools that we want, and that are tailored and chosen for a given setting, is going to make a big difference. So I think there's how can we make our tools better to make the logistics challenge easier? But then there's no way around the fact that there's a needed investment in better supply chain and logistics to get the right things to where they need to be in response to better on the ground measurements.
So I'm gonna call it my colleague Sheila, but before that, there is a related study here. This is from Zambia.
Mm-hmm.
This is actually done by our colleagues from PMI. So Meera, you're probably conversant with this study much more. And here they use MDA as well, IRS, ITNs. And then they demonstrate that, in low transmission settings, you see some additional benefit there of adding MTA. I have a tangential question here for you, Phillip, and maybe Meera. At the moment when these studies are done, the outcome measure is, case numbers, prevalence or incidence. Usually at the back of my mind, and also because you were saying earlier we need to stop deaths, I am asking, what do you think the result would look like if the outcome here was deaths? Just a random question. Do you think you would see greater impact or less?
It's so just very, very short, and then I'll turn over to Meera. Is that if we look at a malaria death and then work back from there, there were so many ways to stop that death. So many ways to stop that death before it happened. We could have prevented transmission, and there are ways of preventing transmission. We could have reduced the reservoir of infected individuals to reduce the number of infected mosquitoes. We could have killed the mosquitoes before they became infected. We could have kept an infected mosquito from biting that individual. So, MDA drives down the number of infected and infectious individuals. The insecticide-treated nets kill them, and IRS kill the mosquito during the incubation period, and the nets also can protect from that final infected bite. So if someone got infected, that means none of those things happened in that particular case. Then there's you get early in the case when the symptoms start. Is there timely access to a diagnostic that works? Was there access to the healthcare to get that diagnostic? Was the right drug in stock? Was the drug given? And then all of a sudden it becomes a severe case. And then was there kind of some of the treatment for severe malaria and the referral happening? When a death happens, it means that all those different opportunities to stop that death from happening, none of them happened in that case. And so, in terms of the question on in terms of in this particular case in Zambia, I think we would see an impact on deaths as well. But at the same point, if you're just driving down the infectious reservoir, if you're reducing transmission and number of infections and cases, you still have to make sure to have really good case management so that the cases that remain have timely access to diagnosis and treatment, or else there's still a chance that those could progress to death as well. So we can make progress on deaths at any point along that pathway. And if we do all of it, you drive faster progress in reducing deaths. And maybe over to Meera if she wants to kind of add certain things to the importance of what does it take to stop the deaths on that?
Thanks, Phillip. And maybe just to clarify, This work is actually Gates Masepa work. Our team in Zambia works very closely with these colleagues, but I don't want to take credit for work that others have.
Yeah, I just saw the clarification from Larry as well. But regardless, I think this partnership in Zambia is very important, and a lot of the work that Masepa has done and the results that they've produced, the PMI Zambia program is taking on and looking at what of this can be implemented at broader scale. So I think the lessons are very important. One thing I would just point out that the investigators noted here is that there was a benefit of MDA, but the biggest benefit from the treatment side was actually the expansion of community case management. So CCM was strengthened with a much stronger coverage of CHWs. And then the MDA was rolled out on that strong platform. And in fact, even that first step of increasing access to case management actually resulted in some quite major reductions in cases. And so it was almost that to do the MDA, you needed the strong case management platform. And even that first step really gave benefits. So, I think Phillip laid out, of course, when we talk about stopping a death, we often focus on that very last stage of, is the child getting care? And if the care is delayed, are they being treated for severe malaria? And that's absolutely an important step that we are focusing on. But looking at the package together, there's so many points along the way, as he mentioned, that you could prevent that death. And in this case, not being as conversant with the data as maybe others on the call, my guess would be that absolutely, this type of package of interventions that drove down cases, but also expanded access to rapid care would have an impact on preventing deaths as well, because there's a less likelihood that a case would proceed to severe. Oh, thanks a lot. Before we proceed, I just want to ask Sheila and Meera, on the question of community health workers, if I may use that term for now. We have lots of questions for you, so this is going to come as well. But just before we proceed, I want to ask Sheila, did you want to have any additional clarifications before we proceed?
Fred, there are clarifications, I think, in the chat box on net durability and topics like vaccine. I think we can cover that in the next slides. Yeah.
Okay. All right. Thanks. So I think then we can move forward, and Absalan Noor is with us. So Noor, your Twitter feeds are public, so please don't mind. But we, Helen, Phillip, Meera, this is Absalan Noor speaking, having a conversation with our Chai colleagues, Justin Cohen. I think personally that the topic they're discussing is a very important one. And it's been alluded to earlier. I cannot do it a lot of justice, enough justice. So I'm going to invite Samson Kiware to have this conversation with you, because I think it's really important. Samson, please.
All right. Thank you very much, Fredros and Sheila, for inviting me. Good to see Phillip, Helen, and Meera. So can we go to the next slide, please?
All right.
And then we can come back to this, because basically I just have some few questions to see the link between data and the models. So I guess my first question to Phillip will be, if you can talk a little bit about the notion about, junk in, junk out, or garbage in, garbage out, when it comes to the link between data and models, and then we can go from there.
Sure. So I think with the context of Absalan Noor's tweet, which I fully agree with, that right now so much of the burden, reported burden, is an estimate through models, as opposed to an accurate and timely real field data collection. through surveillance, through routine data, through various other factors. And so the point about garbage in, garbage out is an essential one. You know, a model takes in inputs and gives outputs. But I think, you know, where there's a really important role for modeling is to show us the effect of what we don't know. Because we don't have the ability to go out and measure everything. And not every factor, not everything will matter. So what modeling can do is basically look at a range of inputs and say, for the output that we're interested in, say reducing deaths rapidly, then going from there to eliminating transmission, eliminating disease in sequential areas. What are the factors that really matter? What are the uncertainties? What are the things that we know where the data going in is not garbage? Where is the data poor? And where is the data poor in ways that really matter? And so so the point of the modeling exercise in that thing is not to take in garbage data and to say, oh, the garbage out is what we're going to build our program around. It's to say, okay, here's the things where we have tremendous uncertainty about what is supposed to be going in. And it's not only tremendously uncertain, but it's tremendously uncertain and it matters to the output. Because not every input matters to the output either that we're interested in. And so when we look at that, we can see the function from in to out. And we can see the different range of potential inputs. And we can see which ones do we know well, which ones are not garbage, and then which ones do we know poorly and that matter, which are the ones that do we know poorly that don't end up mattering as much in terms of the output of interest. And then that creates a strong investment case and agenda to improve surveillance and improve actual measurements of those things and inputs that matter. And so when modeling is at its best, it's not a replacement for better measurements, it's a driver of better measurements. And it's a way of focusing the attention on those things there. But it's not, it shouldn't be used as we have the garbage in and we're gonna drive the program on the garbage out. But it's part of that overall cycle. And then as data improves, as surveillance improves, we get better results. You can get better estimates of what happens as the next step forward. And it also creates the agenda for what improvements we want to see next. So I think that's what I would start with. As you and Fredros know, I can talk about modeling for a couple hours, but I want to make sure that we have a chance to cover some other things too. But fully agree with Noor's point, fully agree about the concern about garbage in, garbage out. But I think we have to make sure that we understand what we're actually using models for and how does that fit into the overall drive to improve the system overall. I don't know if Helen or Meera want to add on that point.
Meera, do you want to jump in?
I mean, I think Philip provided a comprehensive answer, but I think maybe one other point to make just from the programmatic perspective of one that works across countries is that many times there's good quality and granular data available in certain settings and for certain situations and can be used very well to guide programs. So for example, there are absolutely, hospitals and districts and regions that have great data on the number of deaths and which, communities or districts they're coming from, and then what intervention might need to happen to reduce those deaths. The challenge is that those are, pockets of where there's very useful data that can be used to guide those programmatic decisions. But at the moment, there's so many more places where that level of granular data still needs some improvement before it can drive those local or district or region level decisions. And I think as Philip noted, the models are useful for one perspective, but when it comes to those programmatic decisions, it's not going to be across the whole country. It has to be at those lower level geographies. And that's where in some cases, the data are available and are being acted on. And I think that's a really great model and lesson to try to see how we can replicate that level of data generation and use. It has to happen subnationally. And so no matter what the modeling is in overall mapping isn't going to be sufficient to drive those more local level decisions. It'll never be good enough. It can't be. The data have to be more granular to be actionable.
Okay. So I don't know if Helen, you want to jump in as well?
No, I agree
Okay.
with what both Phillip and Meera have said, and I think some of the tools that are being developed, the genomics, the surveillance systems, the databases that are all being used to collect better data and then act on it and feed that back into models will help. At least we're able to look at trends over time, which does help guide us in terms of the general direction we're going in, and when we may have specific problems that need to be dealt with. So I think it's useful in guiding us in a kind of more general way, but completely agree that there's a need for a lot more granular data and the looking at it at a subnational level is absolutely critical.
All right, thanks. So back to Philip with more questions on modeling. I think this was a quote by George Box, who said that essentially all models are wrong, but some of them are useful. So it's important that you mention some of these advantage of using models. But if we go back a little bit on the WHO estimates for this year and previous years, we do agree that there's very large uncertainties around those numbers. And perhaps this is because of poor data quantities or qualities. So the question is, if you agree with that, it would be really good if we can hear from you a little bit on how do WHO or how do they adjust the numbers that they are normally reported?
Yeah.
And why do they adjust them? Sorry. Why did they adjust them? Yeah.
Yeah. So I think Noor has already done a masterful overview of these things here. I think so. I'll just summarize a few points. About 90% of the burden comes from modeled estimates, and a lot of these model estimates come from a process of using occasional cross-sectional surveys typically every few years to look at what was the prevalence at different households, usually in different clusters throughout the country. And these surveys are important, but they're not as focal, and they're not as timely either, because it's every couple of years. So then the modeling, which is really well done by Malaria Atlas Project and others, can basically look at that and say, okay, here's where we were a few years ago, here's where we are now, and here's correcting for the time of the year relative to the season of transmission when that particular cluster was experiencing transmission, so we can correct for that. How do different spatial correlates, land use and land cover, what agriculture is happening, what vegetation is there, what is the housing, how did patterns of burden look like 5 years ago, and what interventions have been rolled out to come up with this overall cross-cutting estimate. But remember, we're kind of interpolating in between from a couple of years ago to the present one, and then extrapolating forward from there based on these correlates. And as we get better and better data, as we understand more and more how those correlates relate to burden, we can go back and kind of make the whole time series better. But we should also recognize that this is a lot of those burden estimates come from, you have a point 5 years ago, you have a point now, and you kind of now get a better estimate of what things were, say, 2 years ago, and that analysis comes out a year later. So all of a sudden, some of these burden estimates are kind of pointing to what were the patterns of burden 3 years ago, effectively, when you think about what were the data that went into the estimates across a lot of the countries. And this is a essential. So if we actually want to do better, if we want to push forward, we need better data, geolocated and timely. One I think is one of the best examples of this was a BedNet campaign in Benin last year that was actively digitized, to where you could where the national program could actually see what households were receiving their BedNet on a day-by-day basis. And so then you can actually go back and say, where are the gaps? Where are the households that haven't yet received a BedNet while the campaign was still going on? And you can actually go back and fill in the gaps to make sure that places that are, rural, high burden, high risk of malaria in that household have the opportunity to get the BedNet that's needed. So that was on a kind of day-by-day response. This wasn't 2 years later saying, oh, these households were missed and lo and behold, there was malaria there. This is saying right in the day-by-day of the campaign, we are actually improving the coverage of BedNets. And so I think, if we look at the state that we want to get to, it's going to be not just better estimates of burden in the past, but where national programs are owning the data in the fullest senses of the word, and using it, relying on it, improving the data, and using that to drive decisions and actions and deployments on a day-to-day basis. I think that is where we're going to see some really transformational shifts happening, and then having a frequent reporting, a rapid reporting of where community health workers, where facilities are finding cases, so that response to that can happen sooner. So I fully agree with some of the challenges. It's remarkable that we can get the estimates that we have, but we need to go much further than that. And I think when we go not just from what did malaria look like over a year ago to where are things happening this week, and and the national program is looking at that and understanding what is possible, I think we're going to see some remarkable progress.
So
yeah, so we were. Go ahead, Susan.
So just a quick question then, as a modeler, and can you predict for how long we'll still rely on models to help us make this prediction or adjustment?
One of the important things is knowing what models can predict and
yes.
what they can do. And we don't have yet a good model for what you just asked.
Okay.
I think but it does set a really important agenda for overall system improvements that we need to see.
Okay, so Frederick, you can jump in, but I have some other follow-up questions, especially when it comes to NMCP. But go ahead.
Yeah, we can come back to those. I just wanted to point out that we were projecting here some projections that some curves that were made originally by Amelie Batozzi from Institute of Disease Modeling. She posted them on Twitter in the beginning and then later refined them and allowed us to use them, demonstrating very clearly how the uncertainties in the WHO estimates were big in the beginning. There's been a great attempt to reduce that level of uncertainty. But the big message here really is that we need real data from the countries. And so, I mean, this, like Samson was saying, is a topic that will need to be discussed much further. In this masterclass, we have a specific session on sub-national stratification using examples from Tanzania. So we will call in Samson back at that time to bring this, to have that conversation with both Helen and Meera. Before that, very quickly, and I know that Sheila has a number of questions waiting from the chat box, but before we drop on that, one quick question to Helen here, also in line with what Samson was talking about, is about entomology data. Not just data itself, but entomology data. We've asked this question to some of our experts before. The answer has always been a little bit like, okay, what exactly is happening? So to Helen and to Meera, you have your DHI, we have the DHIS2 platform. We have the entomology data that are coming from different villages. The DHIS2 is coming from health facilities. Where do these two things meet? Is it worth trying to get these things together, and how do we do that?
Maybe I'll start and then hand over to Meera. I think one of the big gaps that we have that really needs to be handled is, and that is being done very well in some countries and not so well in others, is this data policy gap and the ability to translate the technical entomological data to the people who are formulating policies and making those policies. And so there's a need to have a better intersection there, so that you can then have appropriate policies for using that data and making decisions. I also think that there's some of the tools that we have today that are used in reporting are or that used for collecting that data in the first place don't necessarily connect data. It's certainly not like the Benin example that Phillip gave of kind of real time, this is where the bed net is. And the more tools we have for faster feedback of data, the better the system will be, because it'll be easier to make decisions or tie decisions to data, rather than having data coming in kind of several months later after you've already made your decision about which bed nets to put out in the community, for example. So some tools in terms of helping to speed up the generation of that critical data required for the decision making will certainly help the system. I'll hand over to Meera and let her give probably a more nuanced answer than me.
Well, actually, I would be curious to hear from the Tanzania NMCP. I believe, Fredros, this is a graphic of the malaria composite database in Tanzania.
Yeah, so you mentioned the Tanzania one, and I mean, this is all we have, right? And we've asked questions around this stratification. Tanzania and Kenya, I have to say Kenya in quotes, because last time there was quite a heated discussion about that. But anyway, we have data from Tanzania here, an excellent example of how to do subnational stratification. Still a few questions on how they link in the entomology data, but I think some of them are on the call as well, they can answer. But I mean, Meera, you work a lot with many countries that are aiming to do this subnational stratification, and it would be nice to hear from you how we play this game going forward. How do we do these linkages?
Right. I think my question was, so I think the diagram you showed is Tanzania's malaria composite database, I believe. And what I was going to ask is, what I would be curious to learn from our colleagues from the program is how they are tying the ENTO data with the case data and other data, because I think that's the big question. There's been, advances made in at least tying, of course, HMIS data with LMIS, commodity data. It's a bit more clear there when your unit is the facility or, the catchment, the ties of how to functionally put the data together. Even though it's still complicated, it's a path that can be followed. I'm not an ENTO monitoring expert, but here the challenge really seems to be how you're tying data that have certain geographic granularity, so maybe facility data, to sentinel site data, which is going to be less granular. You'll have fewer sites and may not always tie one-to-one the ento site to the facility-based data. And so I guess from my perspective, I would be very curious to hear, how those linkages can be made and to what extent they are needed. Because, the other point is that some data absolutely you need down to a very granular geographic level, and you need it quickly to make decisions. Other data, occasionally you're using it to plan the next year's procurements, and you have to extrapolate based on maybe 8 sites, what makes the most sense. So in those cases, what more do you gain from, geographically tying ento data to the facility-based data that's nearby? That's a question I'd be very curious to hear from.
Yeah, so actually now that you ask, let me just pose this question to, do we have anybody from the NMCP? Samson, maybe you can direct us to someone on the call from Tanzania NMCP. I know that our colleagues working with them, like Manuela and Emily, are on the call. Maybe one of you can jump on. If we have someone from NMCP, that would be great, just to explain a little bit. Feel free to unmute yourself. I heard Christian's voice somewhere as well, or people from the NMCP. Come on, guys. If you share this, other countries will learn as well. So, Deus Ishengoma, are you there?
Federos, this is Christian here. Good afternoon.
Hi, Christian.
Everybody.
Yes, please.
Since there doesn't seem to be anybody from either an MCP or the rest of my team, let me quickly maybe enter that. Meera, the point you're making is really good. I think in terms of this composite database, the elements on the case side and the prevalence data is really strong and really good. The link with the entomological data is, I think, can be said still very weak, and it's really not entirely obvious how to really best integrate that. That's really the process in which the team is currently together with NMCP. Then there's another problem which I think we have talked in, or has been talked about in other intervention, and that's how do you analytically then go about using this data? Because we have now a huge amount of data, but the analytical capacity is lagging a little bit behind. And I think more for entomological data than anything else. And that's also something really that needs to be tackled.
And Fredros, okay.
Yes, please.
So just to add, of course, I don't speak for NMCP, and that's why I didn't want to react to that. But there's also an ongoing discussion because, as some of you are aware, we have a well-developed mosquito database management system. You can see it on my background there, to do exactly that, managing entomological studies. And there's ongoing discussion with NMCP on how can they incorporate this into their existing systems. So that discussion is ongoing, and that's why I didn't want to talk more about that, but just thought I should mention that as well. Thanks.
Excellent, excellent. No,
Fredros,
thanks. Go ahead. Fredros,
this is Prosper. I'm not sure if I can jump in as well.
Oh, yeah.
Well, I'm as well not a spokesperson for the National Malaria Control Program, but I've some knowledge of what the surveillance systems are set up. So, I agree with Christian that for the time being, the focus has been on the epidemiological side. But I think the setup of the entomological surveillance system, which is countrywide, is very much keenly informed by the stratification and epidemiological data. So the selection, as Meera was saying initially, how do you match the two? So the first point was a layer of selection criteria that was used to kind of establish the entomological surveillance sites. It had all the considerations, including the epidemiological stratification information.
Like the one we're projecting there, right?
Exactly. Like the one that you're projecting here. So knowing exactly what strata, how many strata you have, and what sort of epidemiological data is being collected. And on top of that, you have an addition of entomological sites. And the reason being that we want at the end of the day to just see, not just to have information on the disease burden, but real to incriminate what vectors are actually responsible, and also to monitor whether or not the interventions that are being deployed in those specific strata have impact on the vector population as well. So issues on, it could be an issue of resistance you really need to understand. So the Sentinel sites for entomological surveillance, they are the sites that do both the susceptibility surveys, but also population surveys, which is longitudinal surveys.
Thanks a lot. And really, one of the purposes of these masterclasses is to try and, if you like, liberate a lot of technical know-how from as many experts as possible. So if, like Meera was asking, I mean, if there's information we can share with other countries, do feel free to do that. Our colleague Deusi Shengoma has just mentioned that he's probably unable to do that now, but he might join us later. I think we'll move on, but before that, I'm going to ask Shayla Ugoma, my colleague Shayla. I know you have a lot of questions you want to ask, so please jump in.
Hi,
and then we
Fredros.
take it up from there. Yes, who is that?
Hi, Fredros. This is Deus. Can you hear me?
Hi, Deus. How are you? Okay, go ahead.
I'm fine. I'm just commuting from Arusha to Dar, and my internet is not.
It's okay. It's okay. I mean, we just wanted to hear local expert voices on this subject. But whenever you're free, maybe you can put it on the chat, and we can take it up from there. Thank you so much, Deus. Truly appreciate it.
Okay, great. So sure.
Yes, no problem. Yeah, Sheila, please.
Yeah, thank you, Fredros. So in the chat box, there's really interesting conversations about larval source management and its implementation and its added advantage. So the discussion there is around the evidence that we have of larval source management, yet this is not being taken up as one of the intervention tools. So the question to both Phillip and Helen and Meera, what is the GETS and PMI standpoint? And what sort of data would you like to see for larval source management to be included as one of the vector control interventions? Can we start with you, Phillip?
Or let's start with Helen on our side. I
Okay.
can chime in a bit more later, but we'll start with her.
Thanks, Philip. So first of all, I think larval source management is absolutely an important critical tool in the malaria toolbox, malaria control toolbox, in the vector control toolbox. We have good evidence from some places that it's been extremely impactful, and WHO has a fairly refined policy that everybody, I'm sure, on this call is aware of, the few fixed and findable. There are increasing efforts to use domestic fundings in many sub-Saharan African countries for doing larval source management, and I think increasing use of BTI. So in terms of our the Gates Foundation position on larval source management, we have, just to kind of take a step back for a moment, we have a fairly well-defined strategy that drives our investments, and that largely certainly in the vector control portfolio, where our investments are in research and development are around the development of new active ingredients, new insecticidal active ingredients to address resistance, formulation of those into existing product classes, such as bed nets and IRS, and finding new ways to enable mosquitoes to interact with an insecticide so that it's not all through contact or the use of a tool indoors. And then we have the genetic-based vector control portfolio, and we have also investments across entomological surveillance. So we're not investing in larval source management or the development of new active ingredients, largely because there are effective products out there that work and that don't require our investment in terms of leveraging development funds to develop new products. So it's not that there's any kind of position against the use of larval source management. It's more that there is, we don't currently have a strategic need to fund a development program for the use of for the development of a new larvicide. I'd just add that there's increasing interest in the use of new tools, not really that new to be honest, but things like satellite imagery, predictive algorithms for helping to find where there are breeding sites and do more effective larviciding programs. And so it may be that through the use of some of these tools, it is easier to scale up in certain places than it has been in the past. And I think that's probably where the direction that larviciding needs to go if it's going to be expanded in multiple countries, because being able to find those breeding sites and effectively treat them so that you have cost-effective programs is really key. Philip, I don't know if you want to add anything.
No, I just think that when we look through the different sets of tools that we have, we're interested in how can we get all the way up to the total effect that we want, and there's different ways of getting there, and some tools will scale with the total number of people, like bed nets are kind of a per capita scaling in terms of the overall cost. Some tools scale based on how much disease there is. And some scale as kind of a function of geographic area in some way. And I think one of the places where LSM has shown some real impact in an effective way has been in some of these urban, peri-urban settings, some very interesting results from a variety of places, where the cost for doing it in a per capita way would be quite high, but the population density is such that kind of approaches that scale in terms of geographic area end up being quite interesting. I think a lot of it comes back to how can it be done logistically as effectively as it needs to be. And driving down. If we come back to the modeling for a moment, LSM is going to be acting on kind of a linear term in the equation for R naught, whereas bed nets with insecticides that kill the mosquito are going to be acting on both the linear term and the exponential term, and actually the squared term as well. For the biting rate.
What are you talking about?
Yeah. Yeah, exactly right. So the equation for R naught for malaria depends on, it's a simple and beautiful equation, and it's one of those. I think there was a MasterClass a few weeks ago that focused for a couple hours on beautiful equations around malaria. But the basic thing is to go into a bit of detail. The terms that affect how intense malaria transmission is going to relate to things like the size of the mosquito population relative to the size of the human population, the human biting rate squared, because there's one bite to infect the mosquito and one bite to infect people again, and then a exponential term related to mosquito mortality. And so, so every one of these terms is an opportunity to reduce transmission. And so if you look at something like larval source management, it has a very nice job of dropping the mosquito population relative to the human population, the linear term at the start of the equation for R naught. But you have to turn that a long way down to get transmission very low, which is why the few fixed findable criteria is there, because it's that kind of characterizes what does it take to make it more straightforward to do a job of reducing R naught by a dramatic level. Now, I think one of the big open questions is going to be how to do that how to translate few fixed findable into an increasing set of settings done really well to get that as close to that term as close to zero as possible. But then, so bed nets both reduce the number of mosquitoes, they reduce the biting rates. So that squared term of per mosquito, the rate at which they feed on humans. And then there's also, they adjust the mortality term, which is the exponential. So that is part of the math that's driven a push towards the bed nets. But in the end, it just comes back to what is the effect that we want to get to, and can we do that? So what are the tool sets? What is the satellite imagery? What is the kind of image analysis? What are the ways of deploying the larvicides that could actually translate to a high coverage and drive, if you're going to be relying on LSM, driving that linear term as close to zero as possible in an effective way. And I think there's an interesting research agenda that's possible there. But yes, sorry for the digression into math, but we can actually look and see what is the effect that we want from each of the different tools.
Oh, thanks. Shall I, if you don't mind, we carry on from there with this, and then we come back to the chat questions, just for time.
Yes, that's okay. That's okay.
Exactly. So Phillip, you're talking about, how these interventions work. Here's a perfect example, work by Bill Hawley from Western Kenya in I believe the 90s or early 2000s. I don't remember exactly when. A fantastic example of how bed nets provided protection, not only to the people who slept under the nets, but also to the people who didn't sleep under the bed nets, in the non-users. Now, Helen, there's one of the big questions here, and some of the slides that we are not showing you are the main guiding questions guiding the masterclass here. One of them is on the question of whether insecticide resistance is actually impacting on bed nets. And it appears that because of insecticide resistance, you no longer have this additional benefit that you have over here. But somehow you still retain a certain protection from the nets. And there is now a growing move from the communities to look at what else, what the additional value we can get. So I guess the question for us, to you and our colleagues from PMI, is the evidence that we have right now on whether insecticide is a big factor or against ITNs or not. How strong is that evidence, and how much should we rely on it in terms of the next versions of ITNs?
So it's a complex question to unpack, because you have the dual effect of the protective physical barrier of the net and the insecticide on top. But I think you have pretty good evidence today that shows that the first effect of bed nets that kind of goes when you have high levels of resistance is this blood feeding protection that pyrethroids typically give. And pyrethroids give that because they have this excito-repellent effect, which basically prevents the mosquito from feeding through the net or finding those holes in the nets when the nets are damaged. there may still be enough kill in some areas with resistance to maintain some level of efficacy, but there are countries where we can see that you have bed nets coming fresh out of the packet and the insecticide is not killing. It's like you have an untreated bed net. And so I think given it's really difficult to make these direct correlations. It's much harder to do this in entomology than it is with drugs. With drugs, you can a person takes the drug, you can measure directly the effect on the parasite in the body and the amount of drug in the blood, and it's a direct comparison. For entomological measures, there's all of these other factors in between that contribute. But I think that we have enough evidence today to kind of sound the alarms, and they have been sounding for quite some time. The pyrethroids were absolutely fantastic molecules that took us very, very far, and were absolutely wonderful because of their applicability to the use on long-lasting nets. They have a long residual lifetime. They're relatively safe in terms of the contact with humans. And it is a challenge to find molecules that can replace the attributes of pyrethroids on bed nets in terms of their safety and efficacy, and also that have this kind of excito-repellent aspect that provides this blood feeding inhibition. So as you know, and I think it was mentioned on one of the previous slides, we do now have bed nets that are being tested and slowly rolled out that have an additional new active ingredient on there. And of course, before that, there were the bed nets with the PBO, piperonal butoxide, the synergists to help increase the efficacy of the pyrethroid. And hopefully there's a lot of data generation going on right now, and hopefully we'll see the impact of those in terms of regaining some of the efficacy that we saw in the early days of the use of pyrethroids. Just to add to that, I think to add to the complexity, it's because resistance is not uniform. You don't see a uniform decline across the board everywhere where pyrethroid nets are used. In some places they may still be working very well, in other places they're really not working at all. So it really points again to the need for a good data to be able to, and subnational data to be able to figure out what your resistance levels are, what's working, and help you plan what bed net is the right one for that area.
Thank you so much, Helen. Sheila, please.
Yeah, thank you. So on the topic of bed nets and the efficacy of the bed nets, so recent data has been coming out indicating that bed nets don't really last long enough. They don't last the 3 years. You find that their efficacy lasts a lot shorter, and sometimes by the time programs get onto providing or distributing nets, they find that the nets that were distributed previously are at about 50%. So how can we support national malaria programs to ensure that nets last as long as they're required? Or, for instance, what are the mitigating structures that we can put in place to ensure that the nets are actually durable and are actually effective as they're intended to? The question is to all the speakers.
Shall I take that one, and then maybe Meera can add in?
Yes, please.
So the first critical thing, there's been quite a lot of work over the last decade on developing new test methods for measuring the physical integrity of bednet fabric. And there are there's some SOPs that are now being written, and it will give us the ability to have a much more comprehensive view of the physical strength of the bednet fabric. And so updating product specifications so that there is a broader range of measures to describe the quality of the bednet, the performance criteria of those bednets is really critical, because today we really don't have enough. The specifications are a kind of bare bones. If you look at any health product, anything, including a sanitary towel, you will have more measures of physical integrity on those products than you do on a bednet today. And so there's really a need to increase the specifications so that all of the bednets on the market can basically increase their quality. And hopefully then we can get to a point where those nets will last longer. It clearly has to be combined with the right messaging that goes out in terms of how those bed nets are used and how they're taken care of when people mend them, mend holes. Clearly that's absolutely important. And there's been some fantastic work by Albert Killian and Hannah Conker showing the types of holes and the different use patterns that can lead to the destruction of bed nets. But the conversation really needs to be far broader than that, because across our community there's a need to we're kind of at a race to the bottom where the price pressure on these products is so severe that we're at a place where kind of as much has been stripped out as possible to enable to where we're in a market where the quality of the products that we have today are not what they were when we started, and that means a broader conversation with stakeholders around how much they're willing to pay for these products, so that we are delivering again what is intended. Again, if you look at if you were to go to a store and buy a shirt and your shirt fell apart after the first wear, you would take it back and complain. And the fact that that's essentially not happening with bed nets is absolutely shocking, given how many are procured every year and given out. So I completely agree. It is a very important issue and really needs to be tackled, but across the board. So right from the core specifications all the way through to discussions at a global level with those global procurers and WHO and others. Meera, I don't know if you want to add anything on to that.
Sure, and just to echo Helen's points, this isn't my area of expertise, but I know that our PMI vector control and supply chain colleagues have been in many of those discussions in terms of, looking at what specifications just needs to be, potentially revisited. And as a major procurer, we have a role in the past. We have actually been able to influence some of these specifications and to be able to do that in the future together with Global Fund and others to really drive these decisions. It is a challenge when we've pushed these markets to the lowest prices and now recognizing that actually, we need to be able to get more for the dollars spent. And then also noting that we have been supporting durability monitoring, and a lot of those results are coming out now. And so it's important to make sure that those findings are then feeding into not only what does it mean for the current nets that are available, but what can we actually do to improve the next set of products.
Thank you.
Thank you.
I just wanted to add one thing on this point, and is that I think the points that Helen and Meera have been making really emphasize how important our metrics are. What are we measuring, and what number are we trying to drive up? And I think what happens if we're trying to just drive up coverage, or even just total nets distributed, you end up kind of with a race to the bottom in terms of price, and that has real effect in terms of durability, in terms of use of insecticide. If we're instead trying to maximize impact, that may mean the use of more expensive nets with more durable construction, and in the case of pyrethroid resistance, maybe different active ingredients. And so it may end up being a case of fewer nets, but better nets, actually optimizing impact in other places. So we should just note that maximizing coverage is not always the same thing as maximizing impact. And if we're actually interested in maximizing impact, then we need to look very rigorously and carefully at what is required to actually do so. And this is where cost effectiveness comes in, as far as it has both the cost and the effectiveness. And if you pay more to get more than that, you can actually get more cost effectiveness sometimes with a better net. So there's a lot to think about on this. Yeah, over.
So, I mean, that's an important point you raise. I'm tempted to skip some slides so we can ask on that specific question, but just for the note, we would like to liberate some knowledge from Meera's brain on case management in Zanzibar specifically. But because Phillip raised this point, if you don't mind, I'm just going to skip, and then we can finish with this cost effectiveness item, and then come back up here. So please forgive our jumpiness, but yes, Phillip, let me stick with you. Sheila and myself would like to follow this up now that you've raised it. In the GTS document, the first pillar was about scaling up core tools. Scale up, scale up, scale up, make sure as many people have them and as many people use them as possible. But you see, there is also this argument that you're raising that, you tend to get a lot more bang for the buck in the beginning, when you're still like in the 50, 60% coverage, the return on investment is much bigger at that stage. And at a certain level of coverage, it starts to plateau. You're not making a lot of gains, according to this. This is the days before HME was started, when Chris Murray was still at WHO a long time ago. So a very well understood argument in terms of incremental cost effectiveness ratio. So when we make this argument about scaling up certain interventions, how do we integrate this with the idea that at a certain point, you might be better using that additional money to bring in a new tool rather than scale up the core interventions? That's our first question. And the second, do you think, based on your experiences talking to experts on this subject, and maybe Meera can jump in here as well, that this is a question that is impacting bed nets or IRS in any way?
Would love to hear from Meera on this. I think Meera is representing one of the large procurers. I know she's been thinking really carefully about PMI strategy. Would love to hear from her on this, and may have other things to add in, but yeah, I think she'd be very well placed to address this.
Sure. I mean, I think, what you show here, Fredros, is part of the story of kind of what we've seen with progress against malaria overall in the last 20 years. I think we, a little while ago, talked briefly about the overall arc of progress against malaria and what the World Malaria Report is showing. And early on, you get a lot of benefits from the initial scale up. And now we're in a place where we need to apply more tailored tools. So potentially the same bed net with the same insecticide isn't going to work as well everywhere. And we may need to be exploring different delivery methods and different approaches. I'm not just talking about bed nets here, but obviously all the other interventions to really extend the reach. I think, as a global community, we've taken advantage of the channels that have been funded and made available, whether those were existing potentially through ANC, EPI, through other investments. There's been major investments in the net world and mass campaigns. And so I think we've reached, some economy of scale there. But as we then try to look at what is left, we are going to face, potentially rising costs to be able to fill those last gaps. And I think this is a problem that any program faces, is that sort of once you kind of establish the basic foundation and get what you can out of that, the next steps are going to be more expensive, whether that's because you need to use a more expensive tool or because it's going to be harder to reach the people that you're trying to access, that your first pass of interventions have not yet reached.
When you hear sorry to interrupt you, but when you hear the conversations at Global Fund, for example, about the cost of bed nets, usually this conversation is around specific unit values, like, a PBO net is 2.9 or 3, and people do budget with this value. Do you think there's too much assumption about the linearity of these gains, or should that costing be done differently?
I think it's a bit more complicated. Again, not being a supply chain expert, I think there have been efficiencies gained even in bringing prices of some of the newer products down. So it's not all a bad news story in terms of things getting more expensive. I think, there may be some challenges in pushing too hard towards price, and that can be adjusted and maybe should, to make sure we're getting the quality and impact that we need. But there have been benefits in, collectively the procurers coming together to actually do things like the volume guarantees and really trying to bring prices down. So it's a balance. There's work to be done that can actually reduce those costs, but you need to make sure the quality of the product is maintained and you're keeping that market healthy. We picked on the bed nets, but it's a similar issue with all of our other products. RDTs, ACTs, newer ACTs. So this is something where we need to be able to get that balance right of predictable prices that are at a place that are, well negotiated, but giving us what we need from those products.
Thank you. Thank you. Philip, did you want to add?
No, I think that covered a lot of the key points on this. I think this just points to the fact that we need to be continuously evaluating what are we doing, what is the evidence that we're seeing, has situations changed where we're not in a certain part of the curve anymore, and do we need to how do we adapt as far as bringing in some of the new tools and maybe layering in some of the most intense transmission areas and come up with the right mix. And to do that, I think there needs to be a lot of improved data and improved flexibility for national programs to understand what is the local situation and respond to that as effectively as possible. So I think there's a lot that we can all be doing together on this, but Meera's points are essential.
Thank you. Thank you so much. If I hand back to Sheila, we have this question from Zanzibar that we would like to pose. Let me just go back. Yes, so this is a slide from our colleagues from the CCPH, from Manuel Hetzau and colleagues. They initially did some nice work there, case detection, and and looking at how can you improve identification of cases in these low transmission settings, and figured out actually that the existing approaches are leaving out quite a number of cases, and so they kind of thinking about proposing something called focal reactive MDA to mop up areas around these new interventions. So that's a different topic, and we've kind of discussed that with Manuel briefly. But the other thing that you see is that in Zanzibar, as in many other low transmission settings, you have the situation that the rapid diagnostic tests are not necessarily doing as good a job as they should be doing. So, for example, the positive predictive values are not necessarily very good. And yet, in those cases, case management becomes more important than vector control in certain cases. So, to do good case management, you need good diagnostics. In low transmission settings, your diagnostics are not necessarily perfect, except if you have RT-PCR, which you cannot necessarily use for clinical management. From the PMI perspective, and the PMI guidelines for 2022 suggest that ultrasensitive MRDTs are not recommended. So at least this is what we saw when we were preparing for the masterclass. What would you recommend is the best option for improving case management in settings such as this, where RDTs are not perfect, ultrasensitive MRDTs are not recommended, cases are so low that vector control is not necessarily the most cost-effective. How do you do this?
Sure, thanks, Fredros. I think this is a really interesting and timely question. There's been a lot of discussion around the role of more sensitive RDTs in various settings. I think it's important, maybe as we discuss, to differentiate, to start with RDTs as a diagnostic tool for case management, for detecting infections when someone is sick and comes to be tested, versus the role potentially of these more sensitive RDTs to detect asymptomatic infections or for surveillance or screening. So, I think there's evidence being generated of the role of the sensitive RDTs in both cases. Is there an added benefit for detecting symptomatic malaria in a clinical setting? And then is there added benefit in the more surveillance elimination setting to detect asymptomatic infections? My understanding is that so far, there's the evidence is mixed, but there's not necessarily compelling evidence that the more sensitive RDTs are providing a benefit for routine case management. There's still work underway and probably more questions to answer, but many of the data, especially from Africa, are showing that the conventional RDTs are sufficient to diagnose clinical malaria, including in a setting like Zanzibar. On the other hand, Zanzibar is doing quite a bit of reactive case detection. And this study I'm familiar with, and we actually am on the PMI Tanzania team, and with our PMI colleagues and Jamet have been discussing what might we be doing more in the reactive space, noting that the conventional RDTs are missing many of the infections in the household or in the neighboring households. Would it then be beneficial to shift potentially to a very focal MDA? You're using the RDT, you're spending more time and resources, and you're maybe still missing some infections. Since the effort is really opportunistic, that the officer is there and we want to try to clear as many infections as possible, might it not be more efficient and effective to actually shift to targeted, small scale MDA around the index case? So our team is working with Jamet now to consider potentially either an evaluation or some type of research to look at the acceptability and sort of the logistics around what the focal reactive MDA might look like. The data from the infection and the PCR and the RDT sensitivity is indicating that this is probably the way to go, the focal reactive MDA, but there's questions around acceptability, operations, et cetera, that probably need to be answered. In terms of routine case management, we are currently following sort of global guidance, which really is the evidence so far pointing towards conventional RDTs, even in low transmission settings, being sufficient to detect symptomatic infections and differentiate who should be receiving treatment at the facility.
Thank you. Thank you so much for that. Yeah, go ahead, Sheila.
Yeah, I have a follow-up question, Meera. When looking at Zanzibar, is it reasonable to maintain both ITNs and IRS, or should we choose one?
Well, I think there's a whole advisory committee that's working together with the Zanzibar Elimination Program to tackle these questions. But it's a very good question. Given that Zanzibar is now working to scale up PBO-ITNs, and they do appear to be effective, I think this question becomes more and more pertinent as we look to the coming years. If we are able to saturate with the more effective ITNs, then what is the added benefit of IRS? And I think those discussions are ongoing. We certainly want to be careful and deliberate in any decisions that are made for shifts. And so it's important to monitor the coverage and scale up of the PBO-ITNs as the program considers what the future role of IRS is. I know that ZAMUP also uses IRS to a small extent in a reactive capacity. Again, I think there's important questions where it's good to look at the data to see, what added benefit is that bringing in a setting like Zanzibar, where we really have made a lot of progress. There's still, some active areas of transmission, and now the question is really how to tackle those.
Thanks, Meera.
Thank you. Thank you so much. If you guys don't mind, I realize that we are only a few minutes away from 150 minutes allocated. We have two important questions. We can skip the rest. One of them is on SMC, and the other is on community health workers. And then we have one last question on vector control. So, do you allow us to ask? Thank you. So. Okay, so let's start with a question on SMC. Just guiding questions on SMC. Yes. Yeah. So this is another fantastic study coming out of West Africa. As always, PMI has a group of an area they call SMC eligible zone, where SMC promoted. For our colleagues on the line, if you're a vector control person and you're wondering what this is, it's essentially treatment once every month, a monthly interval, given usually to children. According to WHO, you practice this where you don't have IPTI, intermittent preventive treatment for children. And PMI is supporting a lot of this in West Africa, in the Sahel region as well. I wanted to ask Meera two questions here. One is, if you could just elaborate to our colleagues how the PMI strategy for SMC is structured in West Africa. And a follow-up question to that is, we know we had a class with Professor Brian Greenwood a few weeks ago, and he told us about some interesting results that are coming out of West Africa, not yet published, about RTSS. And we wanted to ask you how this might affect your strategy around SMC there. Back to you, please.
Sure, I'll do my best. So maybe just to start with that overall, PMI, as much as possible, tries to align our programmatic guidance based on the guidance that comes from WHO. And so our groups interpreted, the initial recommendations on SMC and then applied that to the countries that PMI is working in to sort of map and look at, which parts of countries would then be eligible according to the criteria set forth by WHO. That being said, of course, each NMCP has also made interpretations of what are SMC eligible zones. So that's always kind of a bit of a back and forth between kind of the WHO guidelines and then the interpretation by the program. And interpretation is an important component of, you know, applying any global guideline in a local context. And so then between those two, then PMI has been steadily expanding our support for SMC in the countries where we work, where SMC is one of the recommended interventions. I think, you know, there's questions now about potentially extending rounds or expanding the age range, and our SMC colleagues are deeply engaged in those discussions with the newly formed, I'm forgetting what it's called. It's not a task force, but the newly formed global SMC group. And so I saw a question from Andre in the comments about PMI's position. And currently, I think we're recognizing that there's some evidence coming out that based on the seasonality, there may be some settings where a fifth round would provide significant added benefit. And then there's research and some data coming out again around the potential benefits of the age expansion. So with any of these evidence that comes out, we always try to work closely with the rest of that kind of global working group to sort of stay in line with, inform, and then look at what that means for our programs and what we can fund. So it's always that balance between interpreting the evidence, what that means for the guidance, and then how that fits in with, you know, the next year, the supply available, what could be expanded and what should be prioritized. In terms of the vaccine, quickly, I know we're running out of time. I think this is an active area of interest for our program and for our US Global Malaria Coordinator. And so I think we'll be having discussions in the coming months about, you know, the potential WHO recommendation that's anticipated and what that means for where the vaccine ought to be prioritized. I think there's a lot of important questions there, given that it needs to be done in the context of other interventions. Does it have added benefit in a setting such as where SMC is deployed? You know, what does that mean for settings where the interventions aren't fully deployed? And, you know, is that fair? So I'll table that one for now, just noting that there's a lot of important questions that need to be answered on prioritizing a new tool like the vaccine.
Thank you. Thank you. And I guess our last question for you, Meera, and then we'll ask Phillip and Helen to finalize this, is on a topic that we know is very dear to PMI right now. Let me just skip to those slides. First of all, congratulations to Raj and to everybody. This is in the latest PMI report. Raj has written a piece in that report, and there is a particular statement that almost, you know, kind of summarizes his own career, and that is this statement here: we must reach the unreached. And when Raj says this, you know, immediately you know that he's talking about, you know, the last mile health workers, community health workers, and so on and so forth. We have a review here that my colleague Shayla pulled up. Shayla, actually, do you want to ask this? Do you want to take this up with Meera?
Yeah, thank you, Fred. So the question is about the future of community health workers, community-led models within the malaria control programs. What does the future look like? Should we be focused? I mean, how does it play out in control settings and elimination settings?
Sure. Well, I think I speak for many of us on the call today to note that the community platform is important in both control and elimination settings. There's been a lot of investment and scale up of ICCM and CHW programs over the past, 10, 15 years. But really, I think the focus now is on strengthening those platforms. a lot is asked of community health workers, and really institutionalizing their role, formalizing their place in the system and the services that they provide is really important. If you want a lot out of the system, you need to be investing and putting the resources in so that they're supported, they're funded, they're equipped, and actually able to carry out their duties in their communities. It sounds like an easy solution, but it's actually not. It's quite a challenging one, but one that's worth the investment and effort. So I think from our perspective, this is an area that we'll continue to be working on, investing in, and hoping to work with our, all of our in-country partners, the ministries of health. This often goes beyond malaria. It's with the child health unit and other resource streams to really strengthen that platform. I think malaria has done a lot to build and extend the community health platform, but it really does have to be a joint effort. Ideally, we don't want just a malaria-only community health worker. They ought to be equipped for the full ICCM package and beyond, depending on what the priorities are in country. So what does it look like? In our dream, I think it looks like a strong, institutionalized extension of the health system, where community health workers are treated as a health worker and compensated and benefited in that way. And I think we'd like to work together with everyone to try to make that happen.
Thank you. Thank you so much. We just noticed that the available evidence suggests that coverage increases, but impact does not necessarily increase. So when we hear that PMI wants to scale this up, a lot of people ask in which format. And I think It's great, the clarification that you're making. Either Phillip or Helen, if you guys want to make any comments on this specific subject as well, to be nice. Or maybe I can ask the questions we have for the two of you, and then you can answer them together, given the time. So we have two questions. The first one is to Helen. Helen, we have here also, we're requesting your review on, I have to find this slide. Sorry, we're jumping this. We are requesting your review on, forgive me guys for the slide mix up. Yeah, we're requesting your review on this, on the PMI, where are we? Don't mind. Good. On the PMI strategy for selecting ITLs. Again, for the benefit of our audience and NMCP officials here, and for the benefits of other vector control experts. According to the PMI plan, the selection for new ITNs starts with the PBO first and then goes to the dual ITNs. There are people who argue that, if there's resistance, just go straight to dual ITNs. Jump the PBO. What is your general review on this specific approach to taking on the next generation bednets, if you may comment?
I think it makes sense given the level of evidence we have on the PBO nets and the level of evidence we have on the other new nets. There's still a lot of work to be done in, for example, developing some of the insecticide resistance assays for the new molecules. And you can get quite a bit of information by doing some relatively simple bioassays with some of the insecticide synergists. But there needs to be some kind of logical pathway to help with decision making. And this is a good start given where we are in the market for PBO nets and the market for the other next generation bed nets.
Would you recommend this for all NMCPs to do this?
I think it's a logical flow, and I mean this is as we get new test methods in for measuring resistance, as we get different data on the various different bed nets that are out there, this kind of decision tree needs to be reassessed to see if there needs to be any changes made based on whatever data is available as things change. So I'm trying to be quick because I'm conscious of the time.
No worries. Okay, that's fine. Last question goes to Philip, and Philip, that's a question on new data that is come out of Uganda now. Tim Bosima's group, Dave Smith and colleagues. This is not published yet, it's a preprint. It talks of a story that we've had for many years, that as malaria transmission goes down, there's some kind of an age shift, but it also emphasizes the importance of asymptomatic cases. And earlier on, we were talking about malaria elimination. And the question here is, if you're working in high transmission settings, how much should you worry about the asymptomatics?
Yeah.
Is this something you worry about only in low transmission settings, or is this something that you worry about even in high transmission settings?
I think this is such a key point, and I think I'll just say a couple things just because this is wrapping up at the end. I think we need to worry about this at high and low transmission intensity. I think the fact that this dynamic exists should shape our strategy. And so when we think about what does it mean to have a sufficient mix of tools, we need to be understanding that this is one of the underlying dynamics. So our approach to the mix of tools, to how do we deploy vector control, what is our surveillance strategy, needs to understand that at both high and low transmission, that this is going to be a important feature. I think the proportion of asymptomatic also depends on, as you go from high to low, how fast it takes you to get there. I think one of the last things within this is, this does reflect that we need more information than what we get just from the total symptomatic case counts. That's important, but it's not necessarily enough. And what are the things that we can do on top of that? I think increasing reliance on genomic epidemiology is a really interesting opportunity within this, to where when you find someone with parasites, whether symptomatic or asymptomatic, you get additional information from that one encounter. You can find out whether the parasites have different levels of drug resistance. You can look at, if you find parasites, look at, different genetic modifications that are different mutations that have happened to the parasite along the way. And you can also identify, if you're doing this enough, you can identify what is characterizing local transmission. Take with the Zanzibar case, for example. When you actually look at some of the molecular data, you can start seeing where are there still pockets of residual transmission, and what reported cases are being driven by reimportation or by travel to an area and then returning with parasites. These are things that information goes far beyond what the just the case counts will get. And I think this is just a really important addition to and we're seeing this improved, we're seeing impact in Senegal, where the genetic epidemiology is helping to distinguish between local transmission and imported transmission in low transmission areas. It's also tracking changes in transmission intensity in the higher transmission areas as things go down. So given this dynamic, I think we realize that we want to have our eyes as wide open as possible to guide each step of the way. And given the fact that there's going to be more malaria than what we are just seeing through the symptomatic cases, we want to make sure that every time we find a case, we're getting as much information as we can out of that. And I think that the genetics and genomics has a really important role to play in helping to guide that.
Thank you so much. And we are speaking with the experts on this subject. We've reached out to Sanga Institute, Broad Institute, and our colleague Deus Shengoma, who is unfortunately traveling. hopefully we will have a dedicated masterclass on genomic surveillance for malaria sometime soon. I think this is bringing us very close to the end. I just want to ask Samson and Shayla if they have any additional questions. Samson and Shayla, please.
So nothing from me. I mean, because of time too, but we will not talk about the career issues related to modeling, but that's fine. Maybe we'll have some time next time.
I think this we must talk about. I think they will, our colleagues will forgive us if we ask those questions. You know? If you want, I will just move the slides, but I think that this is these are important questions. A big reason we do these master classes is really to you know, encourage the people who will do my job and Samson's job. So whatever little word you guys might have for them. Samson, take it off, my friend. I'm sorry I'm interrupting you.
No, that's fine. I guess maybe we start with Phillip and then the rest can just jump in. So specifically on modeling. So enhancing, you know, building the capacity for African scientists to be able to, you know, develop models that are useful. So what's your take on that, and what do you think it will require to be able to make sure that we have that kind of scientists?
So I think this is one of the most exciting frontiers that we're going to see over the coming 5 to 10 years. I think a lot of the work with HBHI is the Hybrid and High Impact Initiative, which is not just starting with the original HBHI countries, but is expanding as a methodology to how can we fight malaria. And so much of this is around empowering national programs to use their data to make decisions and to stratify and to engage political will. I think across all these factors there, having modeling groups that are based in each country and have a strong connection to each NMCP to where you can iterate through and say, how good are our data? What are the implications of this? What are the where are the gaps? Where are data still not good enough to drive a certain question? Where do we need to improve surveillance? I think this is a really important thing there. I think a lot of this starts, there's many things that go well. I think partnering with existing modeling groups can be helpful, but it can't end there. I think there needs to be a focused effort, as is going on, to continue to build and expand and support capacity. But then as capacity is built, that the funders need to be supporting it so that it can be sustained. It can not just be built, but then relied upon and actively exercised by programs to guide the work that's done. So I think this is one of the most exciting prospects. I think that there's going to be such tremendous impact over the decade that comes from groups that are being strengthened and built up right now. And I'm really excited to see the impact that will happen country by country in the years to come. And I think the partnerships that have started and will continue are a key part of that. And I think just within this, I love thinking through questions. I love, but I love for that work to actually be linking to impact. And I think that seeing careers, I think we're seeing so many people who are coming in saying, this is interesting, but it's not just interesting, it can also lead to impact. And I think making sure that we as a global community are encouraging that and supporting that and creating career trajectories and supporting career trajectories so that this love of looking through data and understanding what these data are telling us also has a supported career pathway towards impact. And huge thanks for the opportunity to be here with you all, and I'll turn that over to Helen and Meera for their closing comments as well.
Thanks.
Thanks. Yeah, just to add, Phillip, to yours, I think there's there's an important opportunity to do smarter trial design for measuring the impact of our interventions, and modelers will play a absolutely crucial role in helping with trial design, helping with doing statistical analysis plans, and figuring out how we can get the evidence we need for the health impact of new interventions in as timely a manner as possible. And a quick comment on career paths for entomologists as well. It's something that we think about a lot. It depends where you are. There are some places in the world where entomology is considered a kind of not a primary career that can project you into the future and to have a sustainable career as you mature. And I think there's a need to really think through the companion subjects that are really helpful to go with entomology, that can help build those sustainable career paths to really build a cadre of African scientists that are able to do so much more than field collections of mosquitoes and the analysis. So I think there's a lot of opportunity. I think there's a lot of need for internships with companies, with institutes like Broad Institute and Sanger and others. So yeah, I'll stop there and could continue to talk about this for a long time.
Maybe just in closing, I think a lot of this is also analogous to the area that I know better, which is again, the kind of genetic and genomic capabilities. So I think Helen mentioned that, and Phillip had raised it also. I think similar to the capabilities, the analytics and modeling, we have the same opportunities to really strengthen those networks within Africa, within malaria endemic regions. The model used to be that someone would go off for a master's or a PhD, off the continent, and then come back and establish a lab. And that may still be happening, but we also have opportunities now for collaborations from country to country, and really, the peer networks that can be stronger and more resilient and more effective. And so we're seeing that with some of the parasite genetics and genomics, and it's really exciting. And I think is a good model for a way forward that's sustainable and beneficial. So with that, just wanted to say thank you all for the opportunity to join today.
No, thanks to you.
Thank you, Fred. So back to you, and just to point out that we are one of the beneficiaries of the Gates Foundation support. So thanks for that big time. But Fred, back to you.
Yes, thanks. So Sheila, I'm wondering if Sheila is still with us. Sheila, please. Back to you, Sheila.
Yeah, thank you, Fred. So I think we've come to the end of our masterclass today. And I want to give a big thank you to our speakers today, Phillip, Helen, and Meera, for such excellent discussions and on useful topics. We wish we had more time to cover all the questions that we had prepared for you, but nevertheless, we still had gained a lot of information and knowledge. And we also want to thank all our participants for staying on, for joining and staying on until now. We thank you very much for all the participation in the chat box, and we hope that you'll be able to join us again during our next masterclass. So thank you very much, and all the best to all of you. Thank you, Fred. Thank you, Sam.
Thank you.
Thank you so much for the opportunity to be here. Had a wonderful time, and it's great to see this series. And thanks, Fred, Sheila, Sam. This was a really great experience. Thank you so much.
Thank you all.
Thank you. Thanks. It was an honor. So thank you.
Thank you very much.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.